With regards to the proposed health care plan that's being discussed, part of that plan is rationed health care. And I was just curious as to whether you had an opinion on this or whether you give us some insights as to what the feeling of your group, Dr. DeMarco, would be. Or I see Dr. Call held his hand up first. Why don't you go ahead?
That's fine. I work in internal medicine and geriatrics, and so I deal with hospice patients all the time. I've had multiple patients tell me that this is not the American way. We do not limit care. We do not ration care. If I get sick, Mama had this, I want this, we may have a revolt of our patients. I've had the strongest outpouring from patients about this. And this is an issue I deal with every day with my patients. 65% of my patients are on Medicare. And they are very concerned about this very issue. The patients are. Physicians are as well. The impact upon myself and other peers, if we go to saying, okay, I spend too much money and I won't be in the program anymore, this is what I do. How is that fair?
Very good. Dr. DeMarco.
We concur also. We do not support rationed care in this country. It's just not the American way.
Okay, I have a osteopathic hospital teaching hospital in our medical school in my district, by the way. So welcome.
Thank you,
Dr. Heim. Everybody's got their hand up here. I must have hit a top topic here. Thank you.
Well, I'd just like to point out that I think under our current system, we do ration care. If you do not have health insurance right now, you oftentimes delay or do not get care. That is rationing. I also think, though, that even those people who have insurance currently, I see a disparity, and we all know that there are disparities of care in this country. So I think that when we develop health care reform, we have to look at what are the disparities right now, what's the rationing that's currently going on as we move forward to a different program. But, sir, it exists out there right now, and I face it every day in my active practice.
Okay.
We have a safety net hospital. 18% of our work is uncompensated, coming to close to $300 million a year. Rationing is common in the public programs in England and on the continent, and it is often pegged at a patient's age. And unfortunately, with all the patients, everybody getting older in this country especially, that's when most of the diseases come along that need care. And the cancer statistics that I quoted earlier in my comments may well in part be due to the fact that they have limitations on what care you can get at certain ages, and it's hard to get it right. I think if we follow the council, the Advisory Council of Economic Advisors that was in that June 2nd document from the White House, the inevitable result will be losing public money and probably will make this worse.
Dr. Harbaugh.
I think that the specter of rationing is that someone who doesn't know an individual patient will make a determination that this particular patient cannot receive care that may, in that case, be life-sustaining, and that scares people to death. I don't think we need to go there. If we had better research on what care is truly effective and what care was futile or ineffective, we would take care of a lot of the expense problems that we have now. If you look at the Dartmouth healthcare maps, and I spent a long time at Dartmouth and was part of their surgical outcomes group, if you look at the variability in the number of surgical procedures done from region to region, what you find is that where the indications for surgery are ambiguous, you have a great deal of variability, and it tends to follow the number of surgeons. On the other hand, when you have very clear-cut indications for surgery, you find that the rate of those operations is the same all over the country. So we can do a much better job of finding out clear-cut indications for surgical care, and I'm sure the same is true for other types of care. And the comparative effectiveness approach, I think, if done right, has a lot of merit.
Okay, thank you very much. Thank you, Madam Chair.